speakers for this evening very briefly. So today we are excited to have our second spine session. So the first one, you remember, was a spine trauma session. This one, I'd like to welcome Dr. Chowdhury, who's co-director of the spine program in neurosurgery at Mount Sinai, who trained at Columbia and did a fellowship at Barrow before joining the Mount Sinai faculty in 2001. And he's really overseen the growth of the burgeoning spine program since that time. And then joining him is Dr. Caridi, who trained at Maryland and the Shock Trauma Center there, as well as doing a fellowship in deformity surgery at the Hospital for Special Surgery before joining our program here. And the two of them together have really built up this program and continue to do complex cases on a regular basis, and will impart their knowledge on degenerative and deformity surgery over the next hour. So with that, I will let them take it away.
Okay. Thank you, Peter. Tell me if you can see the screen okay.
Okay.
Okay. Great. So first of all, I'd like to start by thanking Peter and John both for the opportunity to be here. Really, this is a wonderful series in this time of unusual COVID. It's sort of great to take advantage of technology to impart some learning and knowledge in some of the sub-Is and other things that can't take place in normal fashion. Peter and John are both very involved in our educational program and medical students and residents, and really it's a pleasure to be a part of this. Today I'm going to focus mostly on the degenerative spine in the cervical spine region. This is something that I have a particular academic interest in and a fair bit of clinical experience in, but really there's the degenerative spine topic is so broad that I figured I should break it down to something that's a little bit more manageable for a lecture like this, and hopefully we'll have more opportunities in different forums to talk about the other things. So for disclosure, I have one disclosure. I'm a consultant to BK Meditech, which is a new one that's just gotten started, but shouldn't be relevant to anything that I'm talking about today. I thought I'd quickly mention the case that I have, my case tomorrow, and I thought it's kind of relevant to talk about a degenerative active case that I've been thinking about. So this is a patient who was in her early 60s and had presented to me last fall, let's say October. She had come in with primarily lumbar symptoms, but she also said, oh, by the way, yes, I have some cervical symptoms and so forth. And it's a reminder on how sometimes patients present with one problem and you have to have your antennas up to look for other things. And so I sent her the next month. She came back after I sent her for a cervical MRI because on her exam, she had some early signs of myelopathy. She had some gait and balance trouble, which was certainly hard to tease out what's from the lumbar, what's from others. She also had a number of other medical problems, including some diabetes and some rheumatoid arthritis and other problems. So this was her cervical MRI. And, we don't have the full forum to stop and interrupt and ask anyone, but is there any student who wants to just mention what they think they see on this? Anyone want to volunteer? All right, go ahead. I see a hand up.
This is a multi-level upper cervical spine compression at levels C3-4, C4-5, and C5-6, and there is a cord signal change slightly.
Excellent. That is really good. And so this is a degenerative disorder. Is there any other pictures you'd like to see? I'm sorry, what's your name?
My name is Sartaj.
So is there any other imaging views you'd like to see on this?
In a patient like this, we can see a cervical CT, as well as maybe flexion and extension distraction films.
Yeah,
will be helpful to.
I had the CT scan. I don't have it loaded on this talk, but but even just the basics, and these are the axial imaging. And so, the upper left is C2-3, and then C3-4, 4-5, 5-6, and 6-7. You can see, as you mentioned, C3-4, 4-5, and 5-6 have the most significant compression. And, there's a whole bunch of things that can come from that in terms of the basic categories: radiculopathy or myelopathy, or in this case, the patient had both. And you mentioned flexion extension. I actually have an interest in flexion extension MRI scans. And if you look closely, this is on the left, the flexion view, and on the right, the extension view. The dorsal posterior, I don't know, Peter, can you see my arrow when I'm moving it or not? Yes? Okay, good. So, you see it's relatively flat on the flexion view, and there's a little bit of what we call a pincer effect on the other view. So we'll get into that. But the questions that go into this for this patient is obviously, what's the natural history? Is she a surgical candidate? If so, what type of surgery? Their anterior, posterior, and times you have to do combined. If so, which levels would we treat? What is the timing and how urgent is the surgery? What are the risks and benefits? And both perioperative and long-term. So those are the questions that come up. And obviously, how do we make our decisions? There's a lot of different ways we make decisions in medicine and neurosurgery. The consequences of our decisions can be quite significant because we work with areas where even in a simple infection, you're doing a lipoma and you have an infection, it's an annoyance. If you have an infection with a spine case or you have a duotomy and an infection, it can be life-threatening. So because the consequences are high, we have to make our decisions very carefully, perhaps even more than some other types of areas. In terms of decision-making, you can look at the different categories of time. Preoperative, we look at, well, what workup needs to be done. You answered a couple questions on that very well. There's other questions of what non-operative things can be done. How do we select the patients who should have operation? And if you do operate, which approach, whether you use neurologic monitoring, the number of levels, how much extent of surgery do you do? And then post-operative, there's a lot of other decisions we make, whether to use a collar, and if so, how long, how to mobilize them, how to manage the drains, pain management, medications, et cetera, and therapy. So that's fairly obvious for those of you who are interested in neurosurgery. We use these different things that you build up during the course of your training and your experience. And the learning continues even in attending, and I've been attending for 19 years and I continue to learn. And we also look to our literature and our guidelines and other things to kind of help us, right? So the first thing to get into, if you're talking about degenerative cervical disorders, is to remind ourselves that there are many things that can cause cervical symptoms, right? There's the things that are obvious, but obviously there's things that are not necessarily what you see in your neurosurgery clinic, but there's times where people have a vascular problem. They could come in with a dissection, especially if you're in the emergency room, you could see something like that. There are times where people have ENT problems, or someone has reflux and they're having swallowing difficulty from that. There could be orthopedic shoulder issues that mimic some cervical issues for sure. There's times where there's left arm symptoms. I had 2 patients in the office today with left arm symptoms, and we were talking, by the way, have you had your cardiac stuff checked out and worked up? Because every once in a while, it's an early presentation of angina. There are times that there are GI symptoms, infections. Sometimes there's mastoid infections that go into the upper cervical spine. All these things and endocrine problems can come up. So these all can cause cervical symptoms. So you have to have a broad differential, even though we do tend to see most commonly degenerative disorders, and it's very easy to attribute the symptoms to that. It's always important from the medical school point of view, medical student point of view, to remember the very basics of things. And this is, something that you should, if you're interested in neurosurgery, should know cold, but you'd be surprised how sometimes, I remember myself going through, and it was into the middle of my residency, I think, until I really felt I had all of these down and could recognize and pick it up on exam. There's some subtleties of finding weakness and other things. There's dominant arms versus a non-dominant arm, and understanding what's real weakness, what's pain limited. It takes a little bit of an art. It's not so straightforward. One person's exam. We had a patient, I was on call this weekend, we had a patient being told to us that somebody came in with ascending weakness and was at our outside hospital, and they said that there was 2 out of 5 strength. And, this young person, I'm like, oh my goodness, this is horrible. They were talking Guillain-Barré, everything. We said they need a stat MRI. They didn't arrange one right away. And then 24 hours later, we find out that they want to transfer because they're saying they think it's epidural abscess because the CRP was off the charts, which can also come with Guillain-Barré. It turns out the patient got to our ER and the patient was 4 to 4+ out of 5. And so it's just a very interesting thing where ER exams, especially by non-neurosurgery people or even neurology, sometimes it doesn't quite have the same significance as ours. But, you should definitely know the deltoid and C5 and C4-5 roots are affected. That's what the patients I had today both had. The biceps at C6. primarily. Now, there's other roots that can be involved, and there's subtleties about the brachioradialis versus the biceps and how you can sometimes pick that up on exam. And someone has a bicep weak with the brachioradialis, it pulls it in. When they're trying to do a bicep to pull it up, it goes in a little bit. So there's a lot of subtleties to the exam that you can pick up. And spine is still an area, and I'm sure John agrees with this, where the physical exam is much more important for certain meningiomas and other things in the brain. The details on the exam may or may not be as important, although if it's pressing on a third nerve or something else, it might be very important. So, but spine is definitely an area where physical exam matters a lot. And always remember that the C3 to 5 region can actually present as phrenic nerve dysfunction. I have seen an elevated hemidiaphragm from a patient from upper cervical compression and presenting in part with some respiratory dysfunction. So keep that in mind. You have the standards of basics of medical school, this history, physical imaging, and in spine, we sometimes need EMGs, occasionally the neurophysiologic monitoring before. The character of the pain, the distribution of the motor and the sensory, if there's bowel bladder dysfunction in the gait. So I find gait for myelopathy very important. And it's sometimes patients don't even identify that they have any problem, and yet then you put them in tandem gait and, appropriate for age, so you can change what their expectations are. But most people, should be able to do that. And if they're not, there's a reason sometimes. And obviously we want to know how they've responded to non-operative treatments. In the basics of your physical exam, you should know what the Sperling's maneuver is. And basic, the classic one is pressing on the head and so forth. But what I find most helpful on exam is for all my cervical patients, I tell them, because, what we've talked about earlier was the pincer effect, and the compression is worse when the head goes back. So in fact, the patients I had in the office today, I said, well, which is worse? And they said, I feel better when my head is down, and when they feel worse when the head is back, and especially when they tilt the ear to one side or the other. And I think those are very valuable things to both assess on your exam and document on that. And that really typically, like we see in the lumbar spine as well, extension and leaning to the side compresses the neurologic foramen. You obviously want to look at any weakness, asymmetry. It's hard to know exactly what their baseline is. And for many of these people, if they have diabetic neuropathy or other things, their sensory exam can be confounded by that. Reflexes I just mentioned, if they're diabetic, they may not be as hyperreflexic as you would otherwise be. I find the Hoffman sign very relevant for cervical spine disorders. I don't really check the Babinski often. I've not found it to be a very relevant thing on my day-to-day things in my cervical spine practice. Balance, as we mentioned, looking for atrophy. I can't tell you how many times you look at somebody's hand and they don't think they have any weakness, and you look right there and they have some weakness right there between the thumb and index forefinger. So paying attention to that is actually quite relevant, especially when you're trying to predict a prognosis for improvement and other things. And so that's relevant. So you try and piece that all together, the history, the exam, and the imaging, obviously, and that's part of the art of medicine. And you can use the, try and figure out what category of problem they have. And, in this talk, it's really looking at degenerative disorders. You have to remember there's other musculoskeletal things. We don't think of these always, but there's people who have strains and sprains of muscles, especially the time course of their symptoms. One of the patients I saw today has had 5 weeks of symptoms. And so you still don't know for sure. You can have some, you pull a muscle in your leg, it can last a month or two, right? So you really have to make sure you're not operating on something, because, a lot of people have degenerative findings on their spine, and it doesn't mean it necessarily is symptomatic. You have to look at the effect of repetitive motion and other things. This person I'm operating on tomorrow also has diabetes, also has rheumatoid arthritis, also has a history of carpal tunnel syndrome. And so all of these things play into your decision-making and thought process. So from the compression in degenerative disorders, we have, herniated disc and degenerative spondylosis. And I think that word, for those who don't, early in medical school, I don't know if they focus on it quite as much. And it's kind of a general grab bag term we use that can lead to stenosis. Some people use the word arthritis, not typically neurosurgeons, but that's really a very specific inflammatory condition. And I think it's overused where people say, oh, they have a touch of arthritis. And really, sometimes they have florid stenosis and myelopathy and, from spondylosis. And so, because many cervical spine disorders are not overly painful, you can sometimes be kind of underplayed by people. With the cervical spine, in many ways, is like the brain, where it's, you know, primary central nervous system stuff, and there's no major pain receptors in the cervical spine. Obviously, there's other things you have to rule out in the differential, and the MRI usually shows you those things. You have to keep in mind infection. I've seen times where you've seen inflammatory arthritis truly of the cervical spine, and, you know, where you've had to do a biopsy of the facet and, you know, treat it in different ways, infection with antibiotics, or sometimes steroids if it's non-infectious facet arthritis. Instability is usually something that, you know, we think of separately. Deformity and instability is going to be something that John's going to talk about. He's a real expert in all of these things as well, especially deformity. But, you know, this was a patient I treated early in my career, early in her teenage years, and we used it. Before Dr. Morgenstern was at side, I was one of the pediatric neurosurgeons who worked with me on that. She had juvenile rheumatoid arthritis, and she had this, you know, C1-2 instability, and this was the MRI scan, and she was developing myelopathy on that. And the CAT scan on the right was the reduction that we were able to get preoperatively, and we used some halo traction on that, and then we fused her, and she's now more than 10 years out and has done quite well. So in terms of treatment, obviously the general categories are the various non-operative things. Sometimes you give it time and observation to see if it gets better. Rest used to be done a lot. Now we don't do as much period of rest, because if the muscles get weak, you know, if you put someone in a collar for 2 months, they might feel better, but where are they going to be at the end of that? It's the same way we don't use braces quite the same way we used to when I was in training even. You know, physical therapy and rehab plays a strong role both after surgery, pre-surgery, and, you know, increasingly a lot of us believe in this prehab concept of using it for help prepare for surgery and get them through and recover faster. You know, medications and pain management play a role. We don't have time to get into all of that. I am not a big fan of injections in the cervical spine. In the lumbar spine, I'm a big proponent of that where it's indicated. In the cervical spine for facets, it's pretty good, and sometimes for diagnostic reasons. But, you know, there are times I've seen some disasters, and I'm not a huge fan of that, you know, for a variety of reasons. People use acupuncture and other things. You know, what is the role of surgery? You know, if the alternatives are not working and that the likely benefits outweigh the risks, you know, those are things you can consider. And what are the goals of surgery? Obviously, for compression, by definition, we do decompression. For instability, we try and stabilize, which is usually fusion, although there's various forms of dynamic stabilization that are being considered in spine. And obviously, there's ways like, you know, with semi-constrained constructs and other things. People are looking for ways. There's arthroplasty and other things that people are working on and have now a decade or two of experience for arthroplasty. And then for infections, obviously, surgical and medical treatments are sometimes needed. The principles are, you know, certain patients should be considered for, if you have significant weakness, numbness, bowel and bladder. This patient I was seeing that I'm doing surgery on tomorrow, really, obviously, you know, she had a pretty bad MRI, but she also had some weakness, some numbness and myelopathy in exam. But really, she was saying she was getting worse. And even though I was concerned about the neurologic stuff, what brings it to her attention is the degree of radiculopathy and pain. And frankly, if the pain was getting better, I'm not sure she would necessarily be rushing into surgery. But now her pain is bad and worse. She was going to be done, but the COVID delayed things a few months. And that's a whole separate discussion about you know, what things are appropriate to delay and not. And, you know, you always have to keep in mind warning signs for infection or tumor. I always ask about fever, weight changes, night sweats, those type of things. And you know, every once in a while, you pick up something that you didn't really know. That somebody had. You have a long enough career, you find people who have first presentations of lymphoma or other things from their spinal pain syndrome. So in terms of approaches, I'm just checking the time. Yeah, we're doing okay. So, you know, most of you are familiar by now with the general categories, things from the anterior spine. We can have discectomies and fusions. There are some, you know, non-fusion partial discectomies. There's the minimally invasive Joe procedure and other things that people have done. But most of the procedures, anterior cervical foraminotomies, but most of the time for the anterior cervicals, we're fusing, because in the old days when they didn't fuse and did discectomies, there was a lot of kyphosis, there was a lot of pain syndromes and other things. And so we found that it tends to be a very well tolerated operation. Some of our happiest patients are our ACDF patients. You can have one level, multi-levels. You can do corpectomies, and this is a patient of a couple level corpectomy. Increasing now with 2 or more levels of corpectomy, we're doing posterior operations as well. This is one of the earlier versions of the arthroplasty artificial discs. And on the posterior side, there's a variety of things you probably have learned about, where you take out part of the lamina facet complex and do a foraminotomy, often with minimally invasive metrics type things. You can do laminectomy alone, which still has some role, although because it's so easy to put on screws and there's not so much downside. Increasingly, most of the time we do the laminectomies for doing fusion to reduce the chance of post-laminectomy kyphosis. It's a very old patient and they have very bad bone and there's good lordosis preserved, and that gets into the alignment and other things that we're now much more aware. Even in the time Dr. Creedy's been here, I think we've all learned from him about sort of the roles of assessing the overall alignment and what things to do. And I think, you definitely can learn from your colleagues about things that they have expertise on, and we're definitely learning from John on this stuff. Laminoplasty has a role, and it's not used as much in the US, but I've been a part of a trial, an anterior versus posterior trial that the data is still kind of being analyzed and will be coming out, but let's just say that my impressions are that laminoplasty is going to be a lot better than people thought. And I think this probably been underutilized in our country for a variety of reasons. In this combined approaches where sometimes you have to, in fact, this is not, on this past Thursday, I did a 24-year-old with congenital stenosis, severe myelopathy, cord signal change, and I did a front back on the same day, although I usually tend to stage it for older patients on different things. We've had some guidelines that I've been a part of, and this is a reminder to tell you, like, we like to look to the literature to guide us on what surgery is best, but there isn't always a singular answer. So if you go to this article, that was part of, the conclusions of looking at the different ones, and there was many parts of the study, but multiple approaches exist with similar near-term improvements. However, laminectomy alone appeared to have a late deterioration rate that may need to be considered when appropriate. So that's, even though I'm one of the authors on it, I will tell you, it says punting as much as possible. Unfortunately, you really aren't able to get the answer, which means, now I've also been a part of this anterior versus posterior study, but even that, I think what the studies show is both can work, and really you have to individualize to individual patients, and also in your own hands. There's some people who are much slicker at one versus the other, and there's nothing wrong with doing something you get good results on. So, in terms of decision making, as we've talked about, these are some of the things. You have to look at other factors, including the bone quality. So this lady I'm doing tomorrow, she also has Addison's disease, and so she's been on some intermittent steroids and other things. And so, an anterior approach provides a little bit more, to me, better chances of fusion in my hands. It's been, you have to look for other things like OPLL and obviously the surgeon's experience and preference doesn't, as well as the patient's complication and risk tolerance. The people from the front have to worry a little bit more about swallowing dysfunction and so forth. People who come from the back, in my experience, they've had a little bit more in the way of pain disorders that sometimes linger. So I think you have to balance all of these things, and patient's preferences do make a role. And when do you consider the surgery? And for those who are non-surgeons I give this talk to, it's sort of, when do you refer to a surgeon? And obviously, we see people at various stages. Some have seen 5 surgeons and they're here for your opinion on which approach. And others are just brand new and they want to know what's going on and they're not anywhere ready for surgery. And it really depends upon how they get to you and what stage. I'm going to jump to, I'm going to leave this for John, but there's some clear historical things of, this is ankylosing spondylitis, and this is a classic chin on chest deformity. And what's interesting is we look at these pictures, these are the osteotomies in the days before instrumentation. And so they were doing it with Miss Peterson and other osteotomies. And, unfortunately, there was some fairly high morbidities and mortalities with those operations. Thankfully, we've been able to get that down. I'm going to jump to, in my remaining minutes, to a couple words about myelopathy. And but I want to conclude this part, which is that cervical disorders are definitely very common, and the majority of them don't need surgery. And musculoskeletal etiology has to be remembered. For pain alone, you can often use non-operative measures until very late in the course, until it really, the patient, the situation really needs beyond it. So for my patient tomorrow that I'm doing a 3-level anterior cervical, in part for the reasons I mentioned. So you called exactly C3 to 6 on that. I don't think it'll need a posterior. And, you know, patients with a weakness, bowel bladder, progressive deficit merit the early consideration of surgery. Beware of the warning signs. Definitely, increasingly, we all recognize the role for multidisciplinary management. And, you know, it's one of the reasons that John set up a multidisciplinary spine conference where we review things with our neuroradiology colleagues and other people who are of interest to come by to it. And my last couple minutes, I just want to show a couple pictures on cervical myelopathy because that's the case I showed. And the original article on this from 1952, ironically, the name was Brain who published on this article. If you look on the left, this is actually the cadaver specimen of someone with spondylosis. And so you see the pedicles on the side, and these are the ridges. And then on the same patient, this is the actual postmortem of the spinal cord, and you can see the ribbon-like effect exactly where these ridges were. And so it's a mechanical repetitive injury, and that's something that builds up an injury. And I'll just jump quickly to the other picture. I think you can look up the definitions of myelopathy, and this whole differential and other things which we won't have time to, but basically it's a degenerative process that decreases the spinal canal diameter. It can lead to cord impingement, contouring, displacement, compression, and as I mentioned before, the pathogenesis can be related to worsening extension. There's that pincer effect. You see the ligamentum flavum in the back, dorsal buckling, that chronic repetitive spinal injury with the spondylosis and normal movements, and some of them patients have abnormal movements or microtrauma and mechanical stretch. I've seen patients who woke up with new weakness after, let's say, cardiac surgery because they were extended for intubation or something else and or positioned in a certain way. You know, there's static mechanical forces, dynamic mechanical forces, and then some people feel that there's a vascular component also from the spondylosis. And the last thing I'll show you is the histology, and definitely it's a loss of cells. And you have to really kind of explain this to patients because some of them say, you know, I don't have that much pain. Everyone, my physical therapist and my GP keeps telling me, oh, I don't need surgery. And, you know, we don't try to convince patients to need surgery. On the other hand, some of them really have a need for surgery and they're going to be better off. But because pain is what they usually, it's the most common cause of going to a primary care doctor is back pain. So pain is what people attribute as the main reason that they should go to seek doctor and medical care. And cervical spine disorders are sometimes different. So I think I'm going to leave it at that because it's 8:27. I want to give John time and we have a few minutes for questions, but hopefully you got something out of this for one part of cervical degenerative disorders.
There's a good question in the QA box. Can you comment on the selection of artificial disc versus fusion in the cervical spine?
So I think that, you know, when the artificial disc first came out in the early 2000s, everyone who was generally doing the fusions, people kind of dismissed it. They were like, oh, it's not quite as good. So they spent the first 5-10 years trying to prove that they were just as good. And then I think the literature did show it's just as good. And now some people are trying to say that it's better, right? So the reality is it's an interesting, longer discussion than we have time to get into, but I will say that my view is it's fairly equivalent and that the fusion has perhaps and probably a slightly higher adjacent segment problem rate, but lesser chance of a same segment problem rate. And I think that the artificial disc perhaps save you some of the adjacent segment stuff, but the same segment can have set arthritis and posterior things. And ultimately, my main point is, and why I'm not a huge proponent of it is, you know, with hips and knees and other artificial joints, they tend to wear out after 20 years. And the artificial discs haven't even been out in 20 years. And so the people that they're using as the most common population to do it are the younger, more active people. But yet these are the people who are going to have the most runway ahead of decades to use. So it'll be interesting to see as revisions and other things start to become more apparent if these wear out. But hopefully with better technologies, it won't be. And so I think it's a great point. I don't really have a strong, simplistic answer other than to say both are commonly used. My last point is I'm not a big fan of it for myelopathy, where I think the pathogenesis in part the movements in the dorsal ligaments. But I think for radiculopathy, it's a great choice for patients. And we do bring it up as a choice.
And maybe the last question for this half is any intraoperative techniques or preoperative decisions that help reduce the rate of adjacent segment disease?
I think from the posterior side, I think clearly exposing and or manipulating the facets above or below can certainly, you know, if you take down the capsule or you get into it or other things, it can increase the chance. So trying to avoid that. I think that, you know, people have shown for the anterior cervical plates that if you get too close to the next level above or below, it can make a difference. I think, you know, we used to, when I started off, put a needle for localization in the disc space, and now we don't do that because there's been some experimental evidence showing that that increases, even that simple thing is puncturing the disc and causing an annulotomy can cause it. So we tend to do other types of localization, maybe with a distraction pin, which is not going to affect the disc. So these are some things that have been done, and these are the kind of pearls that you pick up. And by just asking the question, I know that you're going to pay attention during your residency and beyond on some of these things. And we're still learning them, but it's a great question.
That's great. Thank you for that discussion of cervical spine. You want to move on to John?
Yeah, I'll start sharing my screen. So first of all, I want to thank you, Peter, for setting all this up, and thank you, Tanvir, for that great talk. So I'm, as Peter told you, I'm John Caridi, and I am a spine surgeon here at Mount Sinai. My particular focus and my practice is on spinal deformity. So I'm going to go over some of the basics and some of the things that we've learned over the years. So I have no disclosures. So there's an old adage that says that all spine surgeons are deformity surgeons. Either you're creating deformity or you're correcting deformity. And I think that that is something very important to remember. So this is my friend, and he was loaned to me by Chris Ames and Sig Bervin at UCSF. And so basically, when we look at the skeleton, we basically operate in what's referred to as a conus of economy. And this term came about from Jean Dubuisset in the early 80s. And so what we look at is the gravity line, and basically gravity has to be pulling us axially toward the ground. And once we move out of this cone, we start to expend more and more energy. So we move outside the cone, and then we use more of our pelvic girdle and more of our lumbar musculature in order to keep us upright. So when you, so as we age, the discs basically start to deteriorate and flatten out, and we retrovert our pelvis in order to keep our gaze horizontal, because the whole purpose of our spine is to keep us looking forward. So then you can see that we continue to use that amount of energy. And so once it gets to a point where we can't retrovert our pelvis anymore, then we have to bend our knees and tilt our pelvic girdle even more, which creates even greater forces and more pain. And eventually this is not a tenable situation. And then you see the little old lady on the street who has a walker, and you're left with this patient who has this deformed spine. So that was the original idea. And then this was proven by this article in 2005 5 by Steve Glassman, and this is a very classic article showing that that sagittal balance, which is that gravity line, is very important. So this is referred to as the sagittal vertical axis, and so the greater positivity you have in the sagittal vertical axis, the greater your disability. And so with each occurrence in the spine, you have, each degenerative occurrence, you have to have some sort of compensation from the levels above. So if you have a spondylolisthesis, if you have a collapsed disc, the other segments have to compensate in order to keep that gravity line normal. And so it's very important to keep the lumbar lordosis, the thoracic kyphosis, the cervical kyphosis, all in mind whenever you're doing any type of surgical maneuver. So this is a 16-year-old, obviously with a striking coronal deformity, but something that you need to pay attention to also is her thoracic spine is very flat. So she doesn't have a significant thoracic kyphosis. Therefore, her cervical lordosis is reversed. So she actually has cervical kyphosis. So when we do surgery to correct her sagittal plane, her coronal plane, we have to definitely keep her sagittal plane in mind. And so what you notice is by building in the thoracic kyphosis and correcting the sagittal plane, she ends up with a lordotic cervical spine just because of those reciprocal changes. So when we're evaluating a patient and we're looking at their deformity, you always need a 3-foot standing x-ray that includes the hip joints. And I'm going to go over a few of these parameters. So the pelvic incidence is a morphological parameter that is very important in spine surgery. And it basically defines how your sacrum fits into your pelvis and the angle that exists at. So basically you draw a line from the center of the sacrum to the center of the two femoral heads, and then the angle is between that line and then a perpendicular to the sacral end plate. The average is about 55 degrees, but the more important is this needs to be within 9 degrees of the lumbar lordosis in order for the patient to have pelvic harmony. The pelvic tilt is a parameter that shows how much the patient is retroverting their pelvis. So basically it's a line drawn from the center of the sacrum to the center of the femoral heads compared to a vertical line. So the normal is about 13 degrees. Our goal for a patient is to keep that number less than 20. So as the pelvic tilt increases, the center of gravity moves more posterior toward the femoral heads. And then the sacral slope is similar in that it defines the position of the lumbar spine, because each lumbar vertebrae is then going to be subject to that particular angle. The most you can retrovert your pelvis is to make that value 0. So basically, if you completely horizontalize your sacral end plate, you cannot compensate for your spine deformity anymore. So with these values in mind, the Scoliosis Research Society and Frank Schwab came up with a classification system. The coronal curve types don't really matter very much. The main thing are the sagittal modifiers. And so basically saying that if you take pelvic incidence minus lumbar lordosis, it should be less than 10. Global alignment is that sagittal vertical axis, and a pelvic tilt should be less than 20. And with the goal being to keep all of these in basic basically within normal limits when you're doing a correction. Pierre Roussely is a French surgeon who defined four different types of pelvises. This kind of goes beyond the goal of the talk, but basically it looks at the harmony of the pelvis and the lumbar spine and defines how the pelvis should be aligned with the spine and taking that into consideration. And this is one of the more recent indices that's been created by some of my friends in Turkey, called the Global Alignment and Proportion Scale. And basically it looks at it starts with the pelvic incidence and then looks at the relative values of how the pelvis is basically compensating, and how much of the lumbar lordosis how much of that has been affected. And then it also adds in some an age factor as well. This is basically how you score it. You look at the relative pelvic version. So basically, how much is the pelvis actually moving, what the relative lumbar lordosis is. The lumbar distribution index is very important because 60 to 70% of your lumbar lordosis should be between L4 and S1, and then the remainder from L1 to L4. So you have to be very conscious of what percentage of your lumbar lordosis is coming from each segment of your spine. And then the relative spinal pelvic alignment, similar to that SBA, but a little bit more geared toward looking at how the spine is compared to the pelvis. So once you are able to come up with these parameters, there's a score that's created, and 0 to 2 is proportionate, 3 to 6 is moderately disproportionate, greater than 7 is severely disproportionate. And there's an online calculator, which is what I use when calculating this. So when we think about realigning the spine, we have to remember that the biomechanics of a fused spine are completely different than that of a unfused spine. So the natural movement between each segment is going to be completely restricted when you fuse the spine. And despite severe spondylosis, there still is some movement there. And so you really have to be conscious of a lot of these factors anytime you decide that you're going to put a screw into somebody's back. So there was I think it was Dubosset also, or his partner Yves Cottrell, who said that life is a kyphosing process. So over time, as those discs degenerate, they're going to continue, you're going to basically continue to fall forward, and then the forces will change on your spine. So the gravity then is pulling you forward rather than in an axial orientation. So while life is a kyphosing process, spinal fusion is a flat backing process. So flat back is what we refer to when we say that somebody has had a spinal fusion surgery and they were not placed in the proper alignment, and then they're more forward than they should be. So just to give you an example of how a degenerative spine is different, how a fused spine is different from an unfused spine. So this is a 48-year-old gentleman who presented to my office with back pain and also severe leg pain, which the two were about equal. He's a young guy. He was seen by someone else who recommended that he have a complex surgery to fuse his entire spine and realign him. But when you look at his gap score, and you look at how much he's retroverting his pelvis, his sacral slope is completely parallel, his femoral heads are out here compared to where his lumbar lordosis, compared to where his lumbar spine is, he has a completely flat lumbar spine. His gap score is 11, which is severely disproportionate. But when you see him in the office, what I noticed is that all of his muscles were very tense, but what he was mostly trying to do was trying to get away from his leg pain by leaning forward. And so in looking at his MRI, lying down, he has lumbar lordosis. And his canal is wide open, but what he has is this very small disc herniation affecting that S1 nerve root. So we decided to just try doing a microdiscectomy on him, and lo and behold, he restored his lumbar lordosis himself, and got away without necessarily doing a huge surgery. He may eventually need something done later, but we've at least spared him for the time being, although he needs to lose some weight. So this is one method of doing spinal deformity surgery that's very minimally invasive, is to recognize the pathology and not immediately jump to thinking that everything is going to be a spinal deformity case.
John, can I interrupt you for a question?
Sure.
So there's one question about whether fusion and correction of a thoracic scoliosis would result in spontaneous reduction of other present deformities like a cervical kyphosis in the same patient.
Yeah, so that was what I was talking about when I was saying reciprocal changes, is that if you understand the dynamics of the spine and what is a structural deformity versus a non-structural deformity, you fix the structural problem, and then the non-structural portions of the deformity will correct on their own. And so the example I showed in that young girl is that we corrected her thoracic kyphosis, and then her cervical lordosis essentially came back to normal.
Thanks.
So this is from an old textbook, about a neurology textbook of all things, talking about iatrogenic spinal deformity. I'm not going to go through all of this, but this is one of the most common things that I see, and is that it's patients who have had surgery, have had fusion surgeries performed, who are worse off than where they started. And when you are in practice and you are seeing patients, they will commonly say, "Oh, I know 5 people who've had spinal fusion surgeries, and they're all much worse than when they started. So I definitely don't want a fusion surgery." But this is one of the reasons for that, is that people don't, the physicians who have done those surgeries aren't necessarily paying attention to these principles, and end up with these iatrogenic spinal deformities. So once you identify somebody who has an iatrogenic spinal deformity, you have to fix it. And so typically the way you have to do that is you have to cut away a section of the bone and then realign the spine. So Frank Schwab, again, made a anatomic classification system for spinal osteotomies. So type 1 is just a simple facetectomy. Type 2 is referred to as a Ponte osteotomy, or a Smith-Peterson osteotomy, or the eponymous names. It's bilateral complete facetectomies with compression across this interspace, and then you take away the bottom part of the lamina to prevent any pinching into the canal. Type 3 is what we refer to as a pedicle subtraction osteotomy. So you basically cut a wedge into the vertebral body, removing the facets above and below, and then compress across this. So with a type 1 osteotomy, you can get 3 to 5 degrees of correction. Type 2, up to 10 degrees. Type 3, up to 30 degrees. Type 4 is basically an extended PSO, where you take the disc above as well as the cut a wedge into the bone. You can get theoretically 30 to 40 degrees. Type 5 is what we refer to as a vertebral column resection. So we've completely removed the entire vertebra. You can essentially do whatever get whatever correction you need by removing an entire vertebra. Type 6 is typically seen when the vertebrae have been completely destroyed, or there's some other pathology where you have to remove multiple segments. I'll show you one of those a little bit later. So just to go through some examples of when you would do this. This is a young lady, 48 years old, who's had multiple spinal surgeries. She's had an ALIF. This is something hopefully none of you will ever see in your practices. This is a lumbar artificial disc, which has largely fallen out of favor. She had a posterior fusion, and then she had a standalone lateral fusion. And you can see that she is severely out of balance. Her lumbar spine is completely flat. That even this prosthesis at L4-5 is kyphotic. So this woman needs a significant correction. The good news is that this prosthesis is mobile. So as soon as you release from posterior, you can bend this prosthesis. And so basically by doing just a small type 2 osteotomy, you're able to compress across that L4-5 segment and correct her spine into a more anatomic conformation, and she's a year out and she's doing well. This is a little bit more complicated of a case. This is a 63-year-old lady who's had multiple prior surgeries. These are actually all iliac screws, which she had placed, and she's fused L3 to S1. Similarly, very flat. However, she is solidly fused, so there's no prosthesis to hinge off of. She has a significant coronal deformity, which I'm not showing you, which is why we did this surgery, where we did a pedicle subtraction and aligned her spine properly and made her much more anatomic. She's 2 years, probably 3 years out now, with significant improvements. This is a woman who required a type 5, so she was 43 years old and she had scoliosis surgery as a teenager. This is a Harrington rod, at least the bottom part of a Harrington rod, which was, in my opinion, a rather evil device because it would correct coronal plane deformity and create sagittal plane deformity. And then she had that Harrington rod wired to each lamina. The rod several years before had pulled out, and basically she had a hook sticking through her skin. Her surgeon cut the rod and closed the skin over the exposed rod. So when I saw her in the office, there was about 4 epithelial cells that were covering that. So we took her back and we did an L2 vertebral column resection, brought her back into much more anatomic alignment, got a significant correction on her. She's 7 years post-op and doing well. This is the 32-year-old who presented initially not to me, but to somebody else with severe back pain and frequent vomiting, likely because her xiphoid is pinching into her stomach. And so she would throw up every time she ate. She opted to go for a theoretical minimally invasive surgery in which this cage was placed and fusion done. If you do the measurements, she really didn't correct at all. So there was no resolution of her symptoms. So we did this is a case where you need to do a type 6 osteotomy to remove multiple vertebral bodies and correct her spine. So basically, we removed that cage and some of the bone above and below, and fused her in a correct alignment. So she's no longer vomiting. She's almost a decade out from her surgery and still doing well. So in conclusion, you have to take a lot of things into consideration every time you decide to do a surgery. Fusion really cannot be undone. So if you commit somebody to a fusion, you have to make sure that you're doing it correctly and that is the correct thing for that patient, because it will change their biomechanics. And even if you're not going to do deformity surgery, you have to know these principles, because you can be the one creating the deformity that then one of your colleagues has to fix. So happy to take any questions.
Dr. Marvinson, I have one question, if it's okay for me to ask. This is Clementine. Dr. Caridi, thank you so much for this presentation. I was curious to find out regarding the Schwab classification system. I wanted to know if the scoring is adjusted in any ways to take into consideration the differences between men and women in terms of like spine or bony skeleton, as well as the racial differences. So does the scoring system take that into consideration, or is it not necessary? And the other question that I have, if that's okay, was regarding the last case that you just presented. Given that you have different types of osteotomies, I'm assuming that the procedures also have different lengths. So is there also a different rate of complications based on the duration of the procedures? Thank you.
Okay. Thank you for those questions. So the classification systems don't necessarily take gender or race into consideration. There are certain anatomic considerations in females, such as a wider pelvis, that we just basically understand, but they're not necessarily scored differently based on the classification, and you don't necessarily do a different correction. There are certainly racial differences that have been reported in as far as what the pelvic incidence and the lumbar lordosis in different ethnicities is, but it's not something that would necessarily change the degree to which you would correct the spine. You try and keep everything in alignment. And then to answer your question about complications, these types of surgeries have very high complication rates, 30-40%, and they can be at the time of surgery, they can be a week later, they can be a month later, they can be years later, and can include things like infection is the most common thing, bleeding complications, rod breakage, loss of correction. All of these things can occur remotely or pretty soon after surgery. So you do definitely have to counsel your patients that it's a long road to recovery, and even when you're healed, theoretically 5 years down the road, you still could have a complication.
So I have a good question to end on, and I think you're well situated to answer it, having done an orthopedic spine fellowship. But can you speak to similarities and differences between the orthopedic and the neurosurgical approach to spine surgery?
I think over time, orthopedics and neurosurgery have very much converged in spine. It used to be back when Tanvir and I started many years ago that the neurosurgeon would do the decompression, the orthopedic surgeon would do the fusion, that neurosurgeons didn't touch instrumentation. That's obviously all changed over time. The principles that I am talking about are taught now in neurosurgery residencies as well as in orthopedic fellowships. So I think the actual understanding of spine has benefited from having both specialties involved. You know, the main difference I think between us and the orthopedic surgeons is that we're comfortable inside the dura and they're not. And so, I mean, other than that, there isn't a huge difference.
All right, well, thank you, everyone. This was a great session. I feel like med students don't often get so well immersed in spine. They usually end up in the vascular ORs more than anything else. So it's great to get them some education on this. So thank you both for your time. And thank you, everyone, for joining us tonight. We'll see you on Thursday.
Thanks. Good luck.
Thanks, Peter.
Thank you. Have a